Hello, my name's Amir and today we're going to talk about dyspepsia. What is dyspepsia? It comes from the Greek word meaning indigestion, and it's a collection of symptoms rather than a diagnosis. These symptoms will include things like epigastric pain, discomfort, bloating, nausea and reflux. Okay? And there are many causes for this, but the important thing that we need to exclude, and the one certainly that patients would worry about, would be an upper GI malignancy. So, if we're thinking of an upper GI malignancy, we need to send them straight to the endoscopy suite for an OGD to exclude this. So, obviously we can't be doing this for all patients, so which ones are the ones that we have a low threshold for referring on for this? NICE came out with alarms 55, which is something that we as GPs need to know at the back of our hands when anyone presents with such symptoms. So A, anemia; L, loss of weight; A, reduced appetite; R, recent onset of symptoms; M, melena; S, swallowing problems; and 55 being the cutoff. If you're over 55, and particularly in the context of recent symptoms, then that would meet their fast track criteria. So with these patients, we need to send them, as mentioned, straight for endoscopy within 2 weeks. Now, for all other patients with dyspeptic symptoms, as I've previously mentioned, in the absence of these red flag sinister symptoms, we can reassure them that the probability of finding an upper GI malignancy is very low. So, what do we do about them? Well, history is really the key at this point, trying to find the cause, because there are lots of other causes as we've discussed. What are these causes? Things like gastroesophageal reflux disease, duodenitis, gastritis, peptic ulceration, non-ulcer dyspepsia or functional dyspepsia, and also drugs which can exacerbate the above. So when taking a history, the first thing is really important is just have a look at the drug chart on the medication review list. Are they on an aspirin, a non-steroidal, bisphosphonate? Even things like nitrates and calcium antagonists can cause dyspepsia. Taking a history of the dyspeptic symptoms, is it worse, at the end of the day at night when they're lying flat, particularly in the context of someone that's overweight that eats lots of spicy food? That might point to gastroesophageal reflux disease. Is it associated with them eating food themselves or relieved by eating food? Again, that would point to peptic ulceration. The key is we've got time to try and help their symptoms. So NICE, again, devised really important flow chart which can be found on Clinical Guideline 17, and there's certain things you can do without rushing off to endoscopy are test and treat for H. pylori, and the way you can do that, lots of different ways. The way that we use locally would be serology testing, and if that's positive we eradicate it with triple therapy. Look at the BNF for up-to-date guidance on that. If that's negative, then they should be on a PPI for at least 4 weeks, and then review them again after 4 weeks. If the symptoms are still not better, then you can add a second-line agent like a prokinetic or a H2 antagonist. Now, and then bring them back in 4 weeks, constantly asking them about these important red flag symptoms. Now, if they're better after a couple of months and they're on a PPI and a H2 antagonist or prokinetic and they're feeling okay, you can look at reducing or tapering the dose down and then see how they get on with a regular review. If they're not getting better and it's been a couple of months and we've excluded H. pylori infection, then the time would come for a routine referral to a gastroenterologist, but again constantly reassuring them that nothing sounds particularly sinister in the history. I hope you find the above useful. If you've got any questions or queries, then please let me know at GP Bootcamp. Many thanks. My name's Amir and today we're going to talk about dyspepsia. What is dyspepsia? It comes from the Greek word meaning indigestion. What the hell?